Hello guys, in this discussion we're going to look at gastritis. Unfortunately, I didn't have time to create a PowerPoint presentation like I normally do. But basically here's the framework on how we are going to dive into the topic. So we'll look at the definition, the types of gastritis, we'll look at the consequences of gastritis, we'll look at the clinical features, some diagnostic procedures, as well as the treatment. Okay, now we begin. So gastritis is basically the inflammation of the gastric mucosa. Inflammation of the gastric mucosa, that's gastritis. So gastritis can either be acute gastritis or chronic gastritis. Acute gastritis is as a result of acidic damage to the mucosal cells. This occurs due to an imbalance between the acid production and the mucosal defenses or the mucosal protective barriers. This can be as a consequence of increased acid production or decreased mucosal defenses. So before I proceed, I want you to have a basic picture of what these mucosal protective barriers are all about. So within the lining of the stomach, you have the mucus that is produced by the goblet cells. So this mucus lines the epithelium of the stomach to protect it from the hydrochloric acid, okay, which prevent the acid from coming into direct contact with the lining of the stomach. Okay, you also have the bicarbonate ion, which is secreted to neutralize the acid and prevent damage of the lining of the mucosa. Okay, part of the protective barriers, you have this sufficient blood supply to the gastric mucosa, which is necessary to supply sufficient nutrients to the mucosa, as well as directly help to wash away some of the acid that is secreted in the area. So that is the basic picture that I want you to have as we proceed with this discussion. When we get to refer to mucosal defenses or mucosal protective barrier, think of the mucus secreted to create a barrier for the acid to come into direct contact with the lining of the stomach, thereby protecting it from damage by the hydrochloric acid. And think of also the bicarbonate ions, which are secreted, which neutralize the acid, of course, protecting it from damaging the lining of the stomach. Okay, and think of also the adequate blood supply that is essential to maintain nutrient supply and directly wash away some of the acid that is secreted in the area. And of course, it also helps to promote that adequate secretion of the mucus, within the goblet cells. Okay, so now we move on to risk factors of this acute gastritis, which will help us understand, because now we know that acute gastritis is as a result of the acidic damage to mucosa cells, which leads to this inflammation of the gastric mucosa, and it occurs due to an imbalance between acid production and mucosal defenses. And we now understand basically what mucosal defenses are. So when we talk of risk factors, I want you to picture it at the back of the mind that they either decrease mucosal defenses or promote the secretion of hydrochloric acid. Okay, so now one of the top risk factors that we need to be familiar with is the use of NSAIDs. So remember that NSAIDs block the production of prostaglandin, via the cyclooxygenase pathway. Okay, so they'll block prostaglandin production. Now, prostaglandin is essential for the gastric mucosal protective defenses, in the sense that prostaglandin decreases acid secretion, it promotes the secretion of bicarbonate ions and mucus, okay, and it also maintains adequate blood supply to the gastric mucosa. And now, because we understand mucosal defenses of mucosal protective barrier, now we understand the importance of prostaglandins within the stomach. Yeah. Now, when you knock out the production of prostaglandins, you end up diminishing those beneficial effects that prostaglandin has on the mucosal protective barrier, which then predisposes an individual to gastritis. Okay. The other risk factor that we need to talk about is alcohol. So heavy alcohol consumption. Alcohol, of course, has the potential to directly cause damage to the stomach epithelial lining, and this, of course, can also be worsened by the hydrochloric acid, leading to gastritis. Okay. Chemotherapy, the way I'd like you to think of chemotherapy as a risk factor for gastritis is in this okay, with so, respect to cancer treatment, because remember that when you talk of chemotherapy, it can be either antimicrobial therapy or cancer therapy. So in this sense, think of it as chemotherapy referring to cancer treatment. So the basic principle in cancer treatment is that the chemotherapeutic the chemotherapy agents that are used, they target rapidly dividing cells. Now, they are not specific to cancerous cells, which are rapidly dividing cells, no, but they also have an effect on other rapidly dividing cells of our body. And some of those rapidly dividing cells are the epithelial cells that line the stomach. Okay, so remember that the epithelial cells that line the stomach are an example of the labile cells, which are rapidly dividing cells of our body. Now, when this chemotherapy is given, it will also knock out the epithelial cells of the stomach, which are also rapidly dividing. And when it knocks them out, it actually impairs that protective barrier of the stomach, predisposing to gastritis. So that's the basic picture that I want you to have it. When you think of chemotherapy as a risk factor, think of it as in chemotherapy targeting rapidly dividing cells and epithelial cells, which also line the stomach, are rapidly dividing cells, both the labile cells, and it knocks them out, impairing that mucosal protective barrier, predisposing to gastritis. The other risk factor we can talk about is severe burns. So remember, in severe burns, there is excessive loss of fluids. This excessive loss of fluid would later on lead to hypovolemia. Hypovolemia would later on lead to inadequate blood supply to the stomach. Of course, we understand the importance of that adequate blood supply to the stomach, that it will help in terms of maintaining nutrient supply, washing away some of the gastric acid that is, of the hydrochloric acid that is secreted, and promoting sufficient secretion of mucus by the goblet cells. So now, in severe burns, you end up having excessive loss of fluids, which will lead to hypovolemia, which is reduced plasma, and later on this would lead to inadequate blood supply to the stomach, which would then impair mucosal protective barrier of the stomach, predisposing to gastritis. Okay, and this is also referred to as a Curling's ulcer. Okay. In the other risk factor we can look at is increased intracranial pressure. So in increased intracranial pressure, this is how I want you to look at it. So when there's increased intracranial pressure, there will be increased vagostimulation. Increased vagostimulation will lead to increased secretion of acetylcholine. This acetylcholine will then stimulate parietal cells to rapidly produce hydrochloric acid, which promotes increased levels of hydrochloric acid, defeating the mucosal protective barrier due to the excessive secretion, leading to gastritis. Okay, so before I proceed, since I've talked of acetylcholine and increased intracranial pressure and how it leads to gastritis, here is some basics that I want you to understand about gastritis. So we have the parietal cells in the stomach, and these parietal cells are the ones that secrete hydrochloric acid and the intrinsic factor. Okay, intrinsic factor aids in vitamin B12 absorption. Hydrochloric acid, of course, we know that it has its effect just locally within the stomach to aid the activation of pepsinogen, and of course it has that antimicrobial effect. Yeah. Okay, so now these parietal cells have three main receptors. It has the histamine receptors, the gastrin receptors, as well as the acetylcholine receptors. And these are the chemicals that influence hydrochloric acid production. Yeah. So histamine, gastrin, acetylcholine, these are the chemicals that have the potential to increase the secretion of hydrochloric acid, and that is the reason why vagus stimulation in increased intracranial pressure will lead to increased production of acetylcholine, and the acetylcholine would lead to increased stimulation of the parietal cells to secrete hydrochloric acid, predisposing to gastritis. I hope that makes sense. And this is referred to as a Cushing's ulcer. So if anybody asks you to explain what Cushing's ulcer is all about, now you understand what it's all about. In shock is also one of the risk factors. How you can view this is that when there's shock, there is decreased cardiac output. Okay, where there is shock, there is decreased cardiac output. The decreased cardiac output would subsequently lead to decreased tissue hypoperfusion. Yeah, and that tissue hypoperfusion in major organs, it would also occur to the stomach. Okay, shock will lead to decreased cardiac output. Decreased cardiac output leads to hypoperfusion or decreased perfusion of major organs, and the stomach is one of those organs that will be hypoperfused. And when the stomach is hypoperfused, meaning it's not receiving the adequate blood supply that is needed. And of course, we understand, because we've talked about it now several times, when it comes to the importance of adequate blood supply to the to the stomach as part of the mucosal protective defenses. Yeah. So basically, that's how shock would lead to gastritis, in that order. So now, here's someone that has gastritis, and we say gastritis is inflammation of the gastric mucosa, and we are still under acute gastritis, where we say this is as a result of acidic damage to the mucosa, which can be due to an imbalance between the acid production and mucosal defenses, where there could be increased production of hydrochloric acid or a decrease in the mucosal defenses. And we've looked at the risk factors. Now we are looking at the consequences, like what could be the outcome of such an event. Okay, so basically what would happen is that there would be inflammation of the superficial lining of the stomach. So there could be superficial inflammation due to that, damage and irritation of the epithelial lining of the stomach. Okay. The other thing that would happen is that there would be erosion. Okay. In some textbook, they will subclassify erosion as erosive gastritis under acute gastritis. Okay, basically what I want you to understand is that this erosion will occur due to loss of that epithelial layer as a result of damage by the acid. Okay, the other thing that would happen is ulceration. So this ulceration would come in due to loss of that mucosal layer due to that persistent damage as a result of the same acid. Yeah, ulceration would occur. Now, when you think of consequences and marry them, as in just like talking of complications, it is important to have a mind that connects ideas. Remember, I always talk about connecting ideas and finding ways of making sense of the discussion. So in this case, think of it, when there's ulceration, this ulceration would later on persist and lead to damage of the vasculature within the submucosa of this, of course, the gastric mucosa, and this would lead to hemorrhage. Okay, so hemorrhage would be one of the complications that would occur. And with persistent ulceration, you would later on also have perforation as a complication, and it would also lead to acute pancreatitis. That's if this perforation is posterior in nature. Okay, so basically that's what would happen, and the consequences of gastritis. Okay, so now let's look at the clinical features. The other consequence that I'll talk about will be under chronic gastritis, and that is gastric carcinoma. It will make more sense when I talk about it under chronic gastritis, but it's one of the complications that would happen in gastritis. Okay, so clinical features. One of the commonest clinical features that a patient would present with is epigastric pain. Yeah, would present with epigastric pain. Others would complain of this pain to be, crampy in nature. Okay, they would also have a heartburn. There would be nausea, vomiting, bloating, yeah, belching, loss of appetite. Yeah, so those are some of the clinical features that an individual with gastritis would present with. But commonly, like in my case, a number of patients that I've attended to usually present with epigastric pain. Yeah, that's the common feature, epigastric pain, which can be crampy in nature, and they would also complain of heartburns, nausea, vomiting, and these are features that I've mentioned. Okay, so now let's look at chronic gastritis. So chronic gastritis has two types. There's the autoimmune type and the H. pylori type. So chronic autoimmune gastritis, this occurs due to autoimmune destruction of the parietal cells in the fundus and the body of the stomach. This autoimmune destruction of the parietal cells would lead to loss of these parietal cells. As a result of the loss of these parietal cells, there will be atrophy of the mucosa, yeah, due to the loss of the parietal cells as a consequence of this autoimmune destruction, of course. So there will be atrophy of the mucosa, and later on there will be a state of aclohydria, which is decreased acid production. This is happening, of course, due to loss of parietal cells which secrete the same hydrochloric acid. The other consequence of this, I like thinking of it more of as a compensatory mechanism to try and maintain the acid secretion in necessary situations. Okay, and this is increase the secretion of gastrin. Remember, gastrin stimulates secretion of hydrochloric acid, and because we're in a state of aclohydria where there's decreased acid secretion due to increase the loss of parietal cells due to autoimmune destruction, the gastrin secretion increases to try and stimulate that acid secretion to have that adequate levels of hydrochloric acid in necessary situations. So there will be increased gastrin secretion. The other thing that will be there as part of this increased gastrin secretion is that there will be antro G cell hyperplasia. So there will also be an increase in the number of these G cells that secrete the same gastrin. Of course, I like picturing it in the sense of that same compensatory mechanism that I've mentioned. Okay, so that's that. The other thing that would happen as a consequence of this autoimmune destruction of the parietal cells is that there would be a megaloblastic anemia. And this type of anemia is referred to as pernicious anemia. Why is this happening? Remember, I mentioned that parietal cells do not only secrete hydrochloric acid, but they also secrete intrinsic factor, which aids in the absorption of vitamin B12. So loss of parietal cells due to autoimmune destruction would lead to a deficiency of intrinsic factor. Deficiency of intrinsic factor would lead to impaired absorption of vitamin B12, later on leading to deficiency of vitamin B12 and megaloblastic anemia. Okay, so that's basically chronic autoimmune gastritis. So now, because you understand what basically happens, you will find that in some textbook they will show the autoimmune type of chronic gastritis as chronic atrophic autoimmune gastritis, or others will just say atrophic autoimmune gastritis. Now we understand why that atrophic term is there. There's atrophy because the loss of parietal cells leads to a decrease in that thickness of the mucosal layer, hence leading to atrophy of the mucosa. And that's why in some textbook you find that atrophy will be part of this type. So the other type of chronic gastritis is the H. pylori gastritis. Okay, so here's the thing that I want you to understand basically. H. pylori can cause both acute gastritis and chronic gastritis, and it is the culprit in about 90% of cases of gastritis. So it is said to be the commonest cause of gastritis. These are some important points that I just want to highlight on this H. pylori gastritis as a type of chronic gastritis. The other thing that I want to mention is that this H. pylori microbe secretes ureases and proteases, which then lead to inflammation and later on ulceration. Okay, as a consequence of this same chronic gastritis. Okay, now remember I said that I'll mention one other complication, which is gastric carcinoma under chronic gastritis. So remember, where there is chronic inflammation, one of the things that would happen is that there will be some sort of adaptive mechanisms that will kick in to try and adapt to this persistent damage that is taking place. And such an adaptive mechanism that occurs within the lining of the stomach is that there will be metaplasia. And this metaplasia is referred to as intestinal metaplasia due to the chronic inflammation that takes place. There will be intestinal metaplasia because now the mucosal, the epithelial lining of the stomach will resemble that of the intestines, where there will be now these columnar cells that have an increased number of goblet cells in them. Okay, so now remember, intestinal metaplasia predisposes to carcinogenic change, yeah, and this would later on lead to gastric carcinoma in a patient with chronic gastritis. Okay, and this is usually this is of course an adenocarcinoma because of that granular nature of of the intestinal metaplasia, or rather let me just say due to the type of epithelial layer that is involved. Okay, so chronic inflammation would lead to metaplasia, and this type of metaplasia will be that intestinal metaplasia, where the normal stomach epithelial lining will resemble that of the intestines, and this predisposes to carcinogenic change and would later on lead to gastric carcinoma. Okay, so that's it about some of the complications that would occur under chronic gastritis. And of course, I've also mentioned specifically under the autoimmune type of chronic gastritis that megaloblastic anemia would be a consequence of such a case. Okay, and we understand why that would happen. Okay, so basically that's it. So when it comes to diagnosis can be aided with an abdominal ultrasound that could show some sort of inflammation in the lining of the stomach. But it's important to remember that gold standard is endoscopy with biopsy, because endoscopy with biopsy would also help to differentiate a benign ulcer from gastric carcinoma, specifically the intestinal type, which usually presents with an ulcer. So yeah, endoscopy with biopsy is gold standard for those reasons, that it can also help to differentiate a benign ulcer from gastric carcinoma. It's very important to understand that point. It's a very key point under these investigations. The other investigation that can be done is urea breath test. Remember, one of the enzymes that is secreted by the H. pylori is the ureases, and the byproduct of this enzyme is urea, of course, and it can be detected via the urea breath test to aid with the diagnosis. Other diagnostic procedures that can be done is stool can be used to detect antigens against the H. pylori, okay, which can also aid with the diagnosis. Now, when it comes to the aspect of treatment, of course, I have already mentioned to say we won't discuss the treatment in details because I plan to do a presentation which is separate on the pharmacological treatment of gastritis, but we'll just look at the basic approach in the treatment of gastritis, just like I did with the previous presentation in asthma management. So now, when it comes to treating gastritis, the basic approach is that antimicrobial agents, one, so this is the first point, one, the antimicrobial agents are used to target the H. pylori, and this includes agents such as clarithromycin, which is a macrolide, and you have other agents such as metronidazole, okay? So antimicrobial agents are used to target the H. pylori. One. So the other thing that you need is that there are agents that are used, and these agents decrease production of hydrochloric acid, and some actually have that beneficial effect in promoting ulcer healing. And basically we have two main classes which fall under this category. We have the proton pump inhibitors, where we have agents such as omeprazole, lansoprazole, rabeprazole, esomeprazole, pantoprazole, such kind of agents, okay? So like I've already said, I won't go into details how basically they work, but at the end of the day, they decrease production of hydrochloric acid, and they have a beneficial effect in promoting ulcer healing, okay? Other agents that decrease production of hydrochloric acid are referred to as the H2 receptor blockers, yeah? And these agents, we have examples such as ranitidine, cimetidine, such kind of agents, okay? The other group of agents that is used are agents that have a mucosal protective barrier, and this includes agents such as misoprostol. Remember that misoprostol is a prostaglandin analog, and we know what prostaglandins do. And it's also very important to understand that this misoprostol, which is a mucosal protective agent, it can be prescribed prophylactically in patients who have chronic illnesses that require management with NSAIDs in a long-term basis. It's also very important to understand that, okay? The other group of agents that is used are agents such as antacids. Yeah, these agents have the potential to directly neutralize the acid and decrease its effect in that manner, okay? And this includes agents such as the aluminium salts and of course the magnesium salts. Okay, so basically that's it. That was gastritis. We've looked at the definition, the types, and we've also looked at the risk factors and how some risk factors lead to gastritis, the consequences, clinical features, and as well as some diagnostic approaches and the basic approach in terms of the management. Okay guys, so this is it. We've come to the end of the discussion. I hope you find this helpful. Thank you for your time. Stay blessed.